Good morning from Germany to my best colleagues in Egypt. I'm very happy to be a part of this very interesting meeting, and I will be talking about the thoracoscopic spine surgery in the prone position and experience in about 2,500 cases. As you all know, since its introduction in the early 90s, separately by Dr. Regan in the States and Rosenthal in Germany, the thoracoscopic spine surgery has been traditionally performed in the lateral position. In 1997, Dr. Böhm and Dr. El Sagir introduced a modification to this technique by performing the surgery in the prone position and using a biportal technique. Since this modification, sporadic authors have reported about the thoracoscopic procedure in the prone position. The published data deal, however, with a limited number of cases and usually without including the whole spectrum of spinal pathologies. The aim of this work is to convey the benefits and safety of this modified technique in the surgical treatment of different spinal pathologies. A retrospective analysis of prospectively collected data was performed for all patients who underwent thoracoscopic spine surgery in the prone position. In Bad Berka Hospital, in all patients, the surgery was performed in the prone position using a biportal technique combined with posterior fixation. A regular single-lumen endotracheal tube was used in the majority of cases. Three-dimensional thoracoscopy was introduced in 2018, and this modality was applied in the last 180 patients. The medical records were reviewed to determine the demographic data, indications for surgery, as well as any approach-related complications necessitating surgical revision in the operating theater. Between 1994 and 2021, 2,496 patients underwent thoracoscopic assisted spinal surgery in the prone position. There were males and females were equal about, and the mean age was 57 years. The whole spectrum of spinal pathologies was approached by this technique. The indications for surgery were as follows: fractures, 621 patients; degenerative disease in 705 patients; deformity surgery in 551 patients, ranging between scoliosis, idiopathic scoliosis, Scheuermann kyphosis, congenital scoliosis, neuromuscular scoliosis, and ankylosing spondylitis; spondylodiscitis in 416 patients, and spinal tumors in 114 patients. These are some examples for the different indications. Fractures is a 40-year-old male patient with a traumatic fracture of T12 and was operated by posterior percutaneous fixation and anterior corpectomy, thoracoscopic assist. This is another example of a 78-year-old female patient with osteoporotic fracture, T12 and L1. She was previously stabilized with cement augmentation, L3 to L4 to L5 in another hospital, and came to us with a fracture of these two vertebrae, and we performed a percutaneous extension of the posterior fixation as well as anterior corpectomy of both vertebral bodies and cage implantation thoracoscopically assisted. In degenerative disease, we used it for discectomy in case of a herniated disc, and the safest approach for exposing the dura involved removing the head of the rib thoracoscopically and sometimes a portion of the pedicle. Examples of deformity cases: this is idiopathic scoliosis treated with anterior thoracoscopic release to restore the sagittal alignment and to get better correction together with the posterior fixation. This is an example in the Scheuermann kyphosis in order to get a better correction and to save fusion segments. In ankylosing spondylitis, this is an example of Anderson lesion treated with anterior thoracoscopic osteotomy together with the posterior fixation, performed percutaneously. And this is the intraoperative pictures from the percutaneous fixation together with the anterior thoracoscopic release. And a third example, again performed percutaneously from behind and anteriorly thoracoscopic assisted. This is another case of angular kyphosis in a 66 years old female patient with bone necrosis at T11 and T12, presenting with angular kyphosis, and she was treated by long segment posterior percutaneous instrumentation and cement augmentation, as well as thoracoscopic anterior corpectomy of T11 and T12, together with vertebral body replacement. In the case of spondylodiscitis, treated also posteriorly percutaneous and anterior thoracoscopic assisted. And in spinal tumors, this is an example of a 60 years old male patient suffering from prostatic carcinoma, again treated with percutaneous fixation, lung segment, and anterior corpectomy. Complications, approach-related complications necessitating surgical revision were reported in 14 patients, 0.6%. And the revision was due to bleeding in 7 patients, residual stenosis in 4 patients, and deep infection in the remaining 3 patients. In summary, advantages of thoracoscopic surgery: better visualization, better skin incision, better illumination and better magnification, less pain post-operative, less morbidity, less infection, and less hospital stay. The limitation is the learning curve is steep. How to make it easy? I would recommend to use a 3-dimensional VET, offers better depth perception during the procedure, and the biportal instead of multiportal VETs. We have these 2 techniques, lateral position VETs and the prone position VETs. What is the difference? In the lateral position thoracoscopy, the conversion to open surgery is easier. This is the main advantage in the lateral position. In the prone position, there are other advantages. No repositioning of the patient is necessary. Better intraoperative 360-degree orientation. Better reduction of kyphosis. Great vessels fall forward. Blood and debris fall anteriorly away from the spine. Double lung ventilation is possible. And the surgeon is sitting. Conclusions: thoracoscopic spine surgery in the prone position using the biportal technique is both safe and effective. The minimally invasive character of the procedure is suitable even for fragile patients. A significant operative time is saved with the elimination of repositioning and redraping before the posterior procedure. All spinal pathology entities necessitating anterior thoracotomy could be treated using this technique, and approach-related complications are rare, with an incidence of 0.6%. Thank you very much.